Recording in
Hey, it's Dr. Bill with just the tip of urology school. And this episode is going to address bladder cancer. There's two basic presentations. One would be superficial or non-muscle invasive bladder cancer. And the other will be muscle invasive bladder cancer involving a deeper layer. So today we're going to look at superficial disease, implying that the muscle layer is not involved. Remember your anatomy that we spoke of in previous discussions. We've got several layers of the bladder. We've got the urothelium, which is the inside skin, if you will, connective tissue, lamina propria, and beyond that, some additional connective tissue and muscle layers, and then a serosal or outer lining of the bladder. All those are important to understand when we're tackling bladder cancer. Uh, the superficial disease really refers to a superficial layer of bladder cancer. Most bladder cancers involve the urothelium or the lining. So again, look at your several layers of the bladder and get a good feel for what those are. Bladder tumors normally present with hematuria, gross hematuria, or microscopic hematuria. And even those who have intermittent bleeding, hey, doc, I noticed some blood 2 months ago, but it hasn't come back since. I went to the doctor. He can't find anything under the microscope. Do I need an evaluation? Your answer as a medical student, resident physician, nurse practitioner, PA is yes, you do need one, because the worst case basis is there is a bladder cancer there that bleeds intermittently. So it's really important for us to be diligent about evaluating our patients. Risk factors, the big one is smoking. Smoking cigarettes is a big issue for years. In fact, there used to be a very strong male to female preponderance as women over the last decades began to take on cigarette smoking more. That shifted a little bit, and now we're all over the place as far as who's smoking and who's not, or actually we're all over the place who admits to smoking. We don't have any strong data on it, but those who smoke marijuana as well, it's burning a leaf, it's smoke, you're inhaling it, and some of those breakdown products are going to line the bladder as well. So I don't have the data, but I'm betting heavy marijuana smokers are at risk as well. We also have industrial exposures to asphalt or dyes, rubber manufacturing, and even arsenic. Although when you think about it, if you have a heavy exposure to arsenic, probably bladder cancer is the least of your worries. Like every other cancer that we see in urology, we're finding a genetic component. So people who have um, a long family history or strong family history of cancers, or who have bladder cancer that has been identified at an early age, really should undergo some genetic testing to get a better understanding of their additional risk factors and familial risk factors as well. Remember your anatomy. The lining of the bladder is going to be similar to the lining of the ureter, as well as the lining of the collecting system of the inside of the kidney. So part of your evaluation is going to be upper tract evaluations with contrast. CT scans of the abdomen and pelvis with contrast is the most current popular modality. When we look at what we're going to be doing with that presentation, how we're going to treat it, we look at two things. We look at TNM staging, which we've mentioned before in other cancers, basically the size of the lesion, whether there is evidence of nodal involvement or evidence of metastatic disease. And we also look at the pathology. How aggressive is the cancer, or what is the level of, based on a number of different evaluations, what is the potential of this disease coming back? So higher aggressiveness of the tissue itself is a big assessment and helps us determine how we should treat this. Again, most bladder cancers are going to be non-muscle invasive. We're going to spend another video on muscle invasive disease, all with a different game plan. The first thing that we need to evaluate is, once we've looked at the urine, identified there is a risk factor, get an upper tract evaluation, usually with CT of the abdomen and pelvis with contrast. I'm old school. I'd like to get an assessment of any abnormal cells, urinary cytology. There's some other ways of looking for abnormal cells in the urine. They're relatively expensive, but do give us some information, something called FISH, F-I-S-H, which you'll read about. Cytologies are good. They're relatively inexpensive, but they have a low sensitivity rate when it comes to lower volume and lower aggressiveness of the disease. Once we have an assessment of those issues with imaging and cytologic evaluations, we want to perform cystoscopy. A very common question you'll hear: well, I've had the CT scan, my urine right now is clear. Do you really need to look inside my bladder? Again, the answer is yes. Superficial, small volume disease can be missed on CT scan, and that's not uncommon. So you want to look for any lesions. You want to identify if what they look like, whether they're sessile, flat, or papillary type, how they look like pretty frond-like, plant-like material. Those typically are cancer, and so we have to biopsy and resect that. We also want to look for a type of bladder cancer, carcinoma in situ, which is highly aggressive but very superficial, and it looks grossly as a red velvety layer along the bladder wall. So treatments are really going to include removal of that tissue, transurethral resection of the bladder tumor, along with, depending upon your comfort level and your clinical acumen, you're also going to consider intravesical chemotherapy or intravesical immunotherapy. BCG is a big item for us in urology. All of these things potentially, all of these interventions intravesically will potentially lower the recurrence rate. And again, with superficial disease, good, if you're going to have bladder cancer, we want it to be superficial, but understand that it can come back frequently, anywhere from 70 to 80% of the time. So your surveillance is going to include routine cystoscopy for the first 2 years, every 3 months. If you're clean after 2 years, you go to every 6 months for 2 years, and cystoscopic evaluation annually with periodic upper tract evaluations. Remember, not only is the urothelium in the bladder, but in the ureter and the collecting portion or the inner portion of the kidney at risk. Remember the value of cytologies as well. This disease, bladder cancer, along with other cancers that we see in urology, is really subject to a lot of research. There are all sorts of variations on the theme. So for those of you who are choosing to work in urology, this is one of the important things to catch up on. So it's such a prominent and common disease. So look at your AUA, look at your updates, look at your journals. Always contact your supervising physician if you have any questions. It's a disease that's common and potentially devastating, like all cancers if missed. So remember to continue to read, continue to add to this basic skeleton of information that we mentioned today, and look for our next video on our next topic of interest. Thanks. This is Dr. Bill with just the tip of urology school tackling superficial or non-muscle invasive bladder cancer.